Assalamu alaikum everyone. My name is Dr. Yasaman. I am the resident of urology. Today's my presentation topic is medical management of the BPH related lower urinary tract symptoms, and the moderator is Dr. Rabiullah. The outlines of my topic is the conservative measures, alpha blockers, 5-alpha reductase inhibitors, and phosphodiesterase inhibitors, anticholinergics, beta-3 agonist, and the phytotherapy. In the conservative management, patients, we can say the life modification, reduce the weight, avoid the constipation, and do the exercise. And the fluid intake, reduce of the fluid containing caffeine, alcohol, artificial sweeteners, and the carbonate drinks. Avoid the insufficient or excessive fluid intake. Reduce the intake of fluid in the evening if the nocturia present. Avoid the take fluid 4 hours before the bedtime. And urethral milking, the post-micturition dribbling can be reduced by drawing the tips of finger behind the scrotum and then pushing up and forward to expel the pooled urine. And alpha adrenergic receptor blockers. Alpha blockers are the first line medical therapy for the lower urinary tract symptoms, second to the BPH. The alpha blockers are preferred over the 5-alpha reductase inhibitors because the former have the faster onset of action, days to few weeks, and improve the symptoms independent of the prostate size. The alpha blockers are the preferred for the patient with lower urinary tract widening systems who have small prostate size and assess the response after 2 weeks. The mechanism of action of alpha blockers. Alpha blocker reduce the dynamic factor causing the BPH symptoms. These drugs competitively antagonize alpha adrenergic receptors, thereby causing the relaxation of the bladder neck, prostatic urethra, and the prostatic smooth muscle. The secondary mechanism of the action may be that induce the prostatic apoptosis, which suggests that these agents may cause shrinkage of the enlarged prostate. The adverse effects, it may drop the blood pressure, dizziness, fainting, fatigue, nasal congestion, abnormal ejaculation, or retrograde ejaculation. The classification of alpha blockers is non-selective, selective, and the miscellaneous. The non-selective further divided into the reversible and the reversible, and the selective alpha 1 blockers and alpha 2 blockers. Here we discuss only alpha 1 blockers. The prazosin. It is the less tachycardia as it lacks the alpha 2 receptor blocking action, decrease the cardiac preload, it suppresses the sympathetic outflow from the CNS. It is the potent inhibitor of the cyclic phosphodiesterase, causing the increase the cyclic MP, which result increase the HDL and decrease the LDL and triglyceride, and relax the smooth muscle in the bladder neck, prostatic urethra, and improve the urine flow in the BPH patient. Here, with alpha blocker, the peripheral blood vessels dilate, and the bladder neck and prostatic urethra relax, and increase the urine flow. The adverse effect of the prazosin. Postural hypotension at the initial dose, first dose effect, syncopal attack. The importance, nasal congestion, GI tract upset, and sodium and the water retention. Alfuzosin. Alfuzosin has an oral effect, and it has to be avoided in the patient with hepatic impairment because it increases the alkaline ALT, resulting the acute liver injury. Sildosin is a newly drug used to treat the sign and symptoms of an enlarged prostate gland. It is the selective alpha 1 antagonist. Smooth muscle tone in the prostate is mediated by the alpha 1 receptor. Blocking them leads to relaxation of the smooth muscle in the bladder neck and prostate, causing improvement of the urine flow and decrease in symptoms of BPH. Terazosin, it is selective for the alpha 1 adenoreceptors. Inhibition of the alpha 1 adenoreceptors result relaxation of smooth muscle in the blood vessel and prostate, lowering the blood pressure and improving the urinary flow. Tamsulicin, it is a uroselective drugs, and it is used in the selective. It is a selective alpha-1 blocker, which are primarily located on the bladder neck and the urethra. It is more selective for the treatment of BPH, better bioavailability than prozasin. The adverse effect is abnormal ejaculation and the intraoperative floppy iris syndrome during the cataract surgery. Then move on 5-alpha reductase inhibitors. The 5-alpha reductase inhibitors are prostatic factor which results in case of the enlarged prostate by approximately 20 to 25% after the 6 month. It is the two subtype of the type 1 and type 2 in the prostate. Majority is type 2 isoenzyme. The finasteride and the dutasteride is both are the 5-alpha reductase inhibitor. The finasteride is the selective type 2 isoenzymes, and the dutasteride is non-selective type of both type 1 and type 2 isoenzymes. When compared with the finasteride and dutasteride, the dutasteride produce a faster and the more complete inhibition of the 5-alpha reductase in the prostate cells. However, no differentiate in the clinical efficacy or adverse effect as demonstrated between two agents. The 5-alpha reductase inhibitor have delayed onset of action, most effective in the patient with moderate LUTS and the larger size of the prostate gland greater than 30 milligram. And the 5-alpha reductase reduce the clinical progression of the BPH, specifically the risk of the developing urinary retention and need for the surgical intervention. 5-alpha reductase inhibitor work by causing the apoptosis of prostatic epithelial cell, leading to reduction in the prostate volume, serum PSA level by 50% after 6 to 12 months. Minimum of the 6 months is required to evaluate the effectiveness of the treatment. And the disadvantage is the patient with moderate to severe symptoms, it will take longer to time determine whether drug is or not effective. Unlike alpha blocker, the 5-alpha reductase used to prevent the BPH-related complication and decrease the progression. The finasteride has been shown to reduce both incidence of the acute urinary retention 50%, 57%, and need for the prostate surgery by 55% in patients with significant enlarged prostate greater than 14 gram. The adverse effect of the 5-alpha reductase inhibitor decrease the libido, erectile dysfunction, ejaculation disorder, gynecomastia, breast tenderness. The combination therapy, the randomized controlled trial published in European Urology conclude that the combination therapy with tamsulicin and dutasteride is superior to the monotherapy with either of these therapies in the reducing the risk of clinical progression of the benign prostatic hyperplasia. This approach might prove an attractive option for the men who have troublesome symptoms and wish to avoid the surgery. Phosphodiesterase inhibitors. The phosphodiesterase is the sildenafil, vardenafil, and the tadalafil. It acts on the smooth muscle which relax. The indication used for the erectile dysfunction and the pulmonary hypertension. The tadalafil is only for the lower urinary tract symptoms. 5-phosphodiesterase may be prescribed alone or along with the alpha blocker or 5-alpha reductase inhibitor. Phosphodiesterase inhibitor inhibit the proliferation and the contraction of the prostatic smooth muscle, enhance the action of the nitric oxide. It does not increase the urinary flow rate or reduce the post-void residual volume. Usually recommended dose is 5 milligram daily. The dose should be reduced 2.5 milligram daily if the creatinine clearance is 30 to 50 ml per minute. The adverse effect of the 5-phosphodiesterase inhibitors are headache, dizziness, dyspepsia, back pain, myalgia. The contraindication, the patient who are taking a nitrate are the patient with unstable angina or uncontrolled high risk of arrhythmia or persistent hypotension, poorly uncontrolled hypertension, The New York Heart Association classification for grade 4 congestive heart failure are patients who had MI within past 2 weeks. The anticholinergic drugs. The anticholinergic drugs are those which antagonize the effect of neurotransmitter acetylcholine on the autonomic effect in the CNS exerted through the muscarinic receptor. Though nicotinic antagonists also block the certain action of acetylcholine, they are referred to as a ganglion blocker and the neuromuscular blocker. The receptors are at the muscarinic receptor site, heart, salivary gland, smooth muscle of the GIT, genitourinary tract, and the urinary bladder. The anticholinergic drugs are oxybutynin, flavuzate, derifenacin, tolterodine, solifenacin. Flavuzate. The mechanism of action, the muscarinic antagonist is spondylitic relief of condition associated with lack of muscle control in the bladder, such as dysuria, urgency, and then nocturia. The indication, urgency, frequency, the nocturia, suprapubic pain, and the incontinent. The adverse effect of the dry mouth, constipation, stomach pain, vomiting, dry eyes, blurred vision. Derifenacin, the mode of action is selective antagonist the M3 receptor, are involved the contraction of the bladder, GIT smooth muscle, saliva production, iris sphincter function. The adverse effect are the dry mouth, constipation, may cause stomach pain, vomiting, dry eyes, and the blood vision. The contraindication, myasthenia gravis, closed angle glaucoma, ulcerative colitis, severe liver disease, and inability to complete empty the bladder. Oxybutynin. Indication, the symptomatic treatment of the overactive bladder which cause the urge incontinence, frequency, and urgency. The mechanism of action is oxybutynin acts as relax the bladder by muscarinic action of the acetylcholine on smooth muscle and not the skeletal muscle. Completely inhibit the prostaglandin type 1, 2, and 3 muscarinic receptor, leading to increase the urine capacity in the bladder and decrease the urine urgency and frequency. The adverse effect is urinary retention, decrease the sweating, dry mouth, decreased bronchial secretion, headache, feeling dizzy and sleepy, GI tract upset, dry eyes. Solifenacin, it is the muscarinic antagonist with antispasmodic properties used to treat urinary incontinence, urgency, urinary frequency associated with overactive bladder. Tolterodine, indicated for the treatment of overactive bladder with symptoms of urgent urinary continence, urgency, and the frequency. The adverse effect is dry mouth, constipation, dry eyes, dry skin, joint pain. The contraindication is myasthenia gravis, closed angle glaucoma, worsening of the glaucoma, and also prolonged QT interval on ECG or torsidy point. Move on the beta 3 agonist. The medical uses of the beta 3 agonist is the urinary bladder, obesity and diabetes patient, the cardiovascular disease. The mechanism action of the antimuscarinic and the beta 3 receptor agonist, it may cause detrusor muscle relaxation, increase the bladder capacity, and do not interfere with voiding process receptor localized at the bladder, so no risk for the cognitive impairment. And the antimuscarinic inhibit the muscarinic receptor, prohibit the detrusor muscle contraction, receptor located throughout the body. The mirabegron is the beta 3 antagonist. It is a selective beta 3 antagonist receptor for the treatment of overactive bladder syndrome. By the stimulation of beta 3, the contraction of smooth muscle of the bladder is decreased and the bladder can store more volume at the given time. Adverse effect, hypertension, nasopharyngitis, urinary tract infection, headache, constipation, upper respiratory tract infection, arthalgia. The phytotherapy. The use of phytotherapy for the treatment of lower unit tracts has greatly increased worldwide past 2 decades. Phytotherapy was the second most commonly prescribed drugs after the alpha-1 blockers. Cerunosa ripens saw palmetto berry. The extract of the berry of the American dwarf palm, most popular and widely studied phytotherapeutic agents for the treatment of lower unit tract symptoms. While the previous studies meta-analysis that suggest similar efficacy to the 5-alpha reductase inhibitor in the term of improvement in the symptoms and the flow rate. But more recent studies have generally failed to confirm the clinically important role for the saw palmetto in the management of BPH. NICE guideline in the UK does not recommend phytotherapy for the lower unit tract symptoms in the men. Similarly, in the USA, phytotherapy is no longer recommended by the American Urology Association, the BPH guideline.